Hello, how are you?
Hello. Can you hear us?
Yes.
Can you hear us?
Yes, we hear you.
Чувате ли ни?
Yes,
Чуваме
yes.
се.
So I would ask Dr. Байрактарова to present the case.
Уважаеми колеги, уважаеми панелисти, за мен е удоволствие да се видим и да ви представя втория случай от нашата болница. Само не си
Can you
виждам
speak in English,
презентацията.
please?
Yes. This is a 65-year-old man who has a lot of concomitant disease. He has arterial hypertension, diabetes, atrial fibrillation, dyslipidemia, and peripheral artery disease. He has psoriasis without treatment. He first presented in our hospital in 2016 with acute left heart failure. That was found to be due to mitral valve regurgitation based on chordal rupture to the posterior mitral leaflet. He had no obstructive coronary artery disease, and he received surgical treatment with metal prosthesis, sodium bicarbonate number 29. He had a non-remarkable post-op period. On the post-op echo, 1 month after the surgery, he had a non-remarkable paravalvular leak in the lateral region, and he didn't receive regular follow-up after that. He reports reduced functional capacity since 2020, and due to concomitant medical happenstances in his life, he didn't see a cardiologist until the beginning of this year, when he was referred again to us in the summer with echo evidence of left and right ventricular dilation and dysfunction. He has moderate tricuspid regurgitation with elevated pulmonary pressures, and the mitral prosthesis was seen with a severe paravalvular leak in the lateral aspect of the ring, approximately around 9 to 10 o'clock. The vena contracta was 7 of the paravalvular leak, and the ratio of the velocity time integrals was above 2. He had anemia and also evidence of hemolysis. So he was referred for interventional closure of the leak.
Okay, Dr. Alexandrov, can you explain your strategy and your decision? Why do you decide to close the paravalvular leak with closure device, not to repair the valve with reoperation?
Okay. Yeah, you see clearly that there is indications. I mean, he has a heart failure, he has hemolysis, so these are the two most valuable indications to close any power valvular leak. So, of course, the reoperation is always a high-risk procedure, and as it is, I mean, the strategy should be try percutaneous first, and if fail, then of course surgery is also an option.
Yes.
For the PVL, mitral PVL, we use transeptal route to go to the mitral valve, but you know, the transeptal puncture for me is the most the thing that really can make your life easy or make the procedure a nightmare. If you don't puncture on the right side, then it's very difficult to reach the paravalvular leak. So in that case, the echocardiography is actually more valuable than the X-ray in this procedure. So I would like to ask Dr. Bayraktarova and Dr. Peneva to show you the images, to show you where is the leak orientated, anterior, medial, lateral, and to explain you why we do the puncture at the certain place.
Pointer ли нямаш?
Не, може ли микрофон да дадете?
Sasha, what is in the general
Виждате 3D. You see the 3D echo images from the TOE. Here is the atrial appendage. Here is from the atrial aspect, the paravalvular leak, approximately at 9 o'clock. This is the mirror side image from the ventricular aspect. You see the pizza of the paravalvular leak here. And that is the images we use to orient the operator how to guide how to put the guide.
So you have two places with the valve dehiscence.
Sorry?
You have two places where the valve is detached from the annulus.
No,
or-
it's only one. It's only one
Okay.
point of.
This is on the
That
lateral.
is the.
Okay, this
on
is
the
from the
lateral
side
side.
of the left atrial appendage.
That's correct. You see the other is from the ventricular side.
What
so
is the
from
size?
below the
What
valve.
is the size of this defect? What is the length and the? What is the length of the defect?
The size was calculated to be around 8 millimeters, 7, 8. The length is 6, maybe 7. Usually we try to oversize at least 30%. So that is our initial strategy, and we will see how it goes.
What type of device you plan to use and what size?
Добре,
Yes.
the measurement of the hole is a very difficult job because we doesn't see late of the communication. We prepare 8 millimeters, no, 12 millimeters diameter vascular plug second generation.
This is AVP2. Yes.
Yes.
AVP2, yes.
Okay.
But how big is the hole? This is very, very difficult job.
Yeah, I think that
We try
probably you
with
will need
12
two
millimeters
plugs for
AVP2.
this hole.
Is these patients need CT assessment to precise the size of the closure of the plug?
I think no, because the hole is like rabbit hole.
Yes.
This is the long tunnel with many curves left to right, up and down with stenosis and dilatation. We doesn't have only one size.
Okay.
Okay, do you want to see the device?
Yes.
Sure,
Sure.
but as I see,
Please,
if
in my hand.
I saw right, you already crossed with what type of sheet you use. This is a Agilis for the transeptal.
Yeah.
This is Agilis,
For the
and
transeptal-
then you
No.
or
For the transeptal is SL.
no. I mean
Schwarz.
the sheet you use after crossing the transeptal.
After crossing, we use the Agilis sheet
Okay.
with a large curve,
Okay.
8.5 French. And then mostly echo guided, we try to advance the tip of the Agilis in front of the defect. Well, after that is a little bit of luck to to cross with. I always use some 5 French catheter. This time it was a multi-purpose, and with 0.35 Terumo wire, you see the crossing of the defect. Then
You were really lucky.
advance. Thank you.
Yes, because the last time when
Yeah.
I made this, I lost 40 minutes to cross the defect.
Okay, now I show you the device. I open the device especially for you. Please, camera in my hands.
So you use 5 French diagnostic catheter or guiding, multi-purpose?
Okay. Попблизу,
Diagnostic.
моля.
Diagnostic, okay.
I open the first disc. Where is the camera? Okay. This is the first disc. And now the body of the device and the second disc. Do you see the device? Okay. We go back. This is the rabbit, and we try to put the rabbit in the hole.
Actually, the most important part now is just to eject all the air. There should be no any air bubbles into the loading
Yeah.
device.
Yeah, it's correct.
This is the most important and most dangerous part from.
But they have transeptal function, so they need to keep the HT
Та накрая вече.
about 300.
Sure.
And
No,
then
this
to
is
the
because of
diagnostic
the air
catheter.
embolization into the brain, and there is there could be during the device release some air embolization. This is what I'm talking about. This is the
Okay.
Yeah,
I flash you one more time.
Dobry is absolutely right, because we can close the PVL and leave the patient without a head. So that's not
exactly,
good.
exactly. Just this is the main risk.
So after we pass with the diagnostic catheter, we change with the stiff wire, unplugged super stiff, and then we advance a 5 French 100 centimeters fortress sheet, through which we are going to, you see now the fortress coming, through which we are going to implant the device.
Sasha, I have
Okay.
a question. Just if you are unable to close the defect with the first device, because then you practically lose the access to the left ventricle. What
Yeah,
would-
for a larger defects, I leave a safety wire inside the ventricle. But for this one, I feel that 112 millimeter plug would be enough. But we could place a second wire. Sometimes I do it like this. I
Yes.
place a Terumo wire.
Because with the
to
Gillis you
have,
have enough space with the 5 French.
Yeah, yeah. Okay, we
Fortress.
can do that, no problem. Yep.
And, which wire are you using now across the leak?
The first one was Stride Terumo, and then they used Amplatz extra stiff.
Да.
And for protection wire, you use PCI wire or
No, it's
Oh,
Terumo wire.
Terumo? Okay.
Terumo, but
Yeah.
sometimes it's difficult when you already have the sheet inside to.
If you have
Find the hole.
V18, I think it will be easier.
I
and
have, yeah.
Maybe with V18 will be easier and enough with the support. Just and will be easier then to
Yeah,
remove it if you close the
we have,
defect with the first device.
We have the Terumo 18, I forgot the name, sorry.
Advantage.
Advantage, yeah, Advantage. 18.
So advantage
Да,
is
игла.
equivalent to V18 from Boston.
Čakaj, stane, može?
You usually use V18 is it?
Yes,
because you have less troubles to pull it.
yes, yes. And actually V18 gives a lot of support. It is 0.18, but gives really good support. And
control is
And
very
the torque control is
Torque
excellent.
very nice.
Despite
Ама
that,
водеща и глашна такива.
advantage is the most,
Значи дай глад.
in my view, the most torqueable wire from all 018 wires.
Sad ćemo i disu na
From Terumo.
This is my favorite to cross the defect.
Yes. So,
But you know, to
Sasho,
do that, I have to remove the fortress from the hole.
yes,
because now
yes, you have this sheet. Okay, if you want, you will place the device just to see, and then we will switch to Pirogov just to see their case, because as far as I know, they are already finished.
Okay, so we put the device, right?
Yes.
Okay?
Yeah.
Okay. Чакай само това да го мръдна напред.
So from the geometry here, I think we can be confident without a safety wire.
Yes, they crossed very well, very easy. But Jeff Moses, during one live case during TCT a couple of years ago, said something very wise in my view: don't take your luck for granted. So, could be. But anyway, they have a very stable position now.
Не спира.
So this is the device.
После. Трябва да го позиционира първо и накрая ще го закача. Искаш ли една лупа?
So you can see actually the echo control, which is absolutely obligatory in those cases. And
We open the right disk. Okay, now we open the body of the device. This is the body. And finally, the second disk. Okay.
bravo. Okay.
Can you check with echo? Yes.
We take
Now we check the valve.
yes. The valve is easy because you can see it on the fluoroscopy, the disc movement.
Yeah.
Sometimes it is even more reliable than echo for the.
Да.
Dr. Bayraktarova, can you step one
Right.
foot to the right
This is
or
the
to the
cranial
left
view.
because okay. And can we see? Yeah, good.
Do you have a mic? Please give them the microphone.
So
We saw that the discs, the opening of the discs completely stopped the paravalvular leak. We are now checking for the gradients of the valve. We saw that the discs of the valve don't seem grossly impinged, but we are obliged to check. We see gradients of 5 to 2, so that's normal. We are going to see with color in all the cuts again.
can you show us the 3D view of the paravalvular leak? If
Yes.
it remains something, just usually just for the audience, because it is very demonstrative about the effect. Yeah. Okay.
Се обърни към нас.
Yes.
Okay. We can release the device.
Yes.
We are agree.
You see here,
Yeah.
you see here the big circular thing is the device.
Yes.
It is still attached to the guiding system, and we don't see any residual leak on the 3D. On the 2D, we usually see just a little bit inside the body of the device, but that is completely normal at this stage.
Super.
May I ask what patient pressure, blood pressure is currently?
It is 100 and
106 by 55.
160.
155.
Very good.
Congratulations.
Congratulations. So,
Do you agree to release the device?
yes, you will
can
release the device and we will switch back in a couple of minutes just...
To see
yes.
the device again.
Okay, just give me a few minutes, yes, and we will come back.
Okay.
So let's go to
Okay.
the Pirogov.
Hello.
Хай, Иване. Голям екип виждаме.
Да, няма място за мен. We are in a very advanced stage of the case, but we will start from the beginning. Dr. Penev will show you the presentation short, because we are moving very fast.
So we have a gentleman, 71 years old. He has history of hypertension, dyslipidemia, controlled hyperthyroidism, as well as normal kidney function. He's also a former smoker.
Oh, maybe we have distal vessel disease here, huh?
He has
we have
a
two, oh,
persistent chest pain, high grade, also
Maybe, yeah.
very frequent
Maybe,
PVCs.
yeah.
He also has a history of a CTO about 80 months. Prior, he had the diagnostic angio. We calculated his scores, JCTO 3 points as well as CASO 3 points. Last year, about 1 year ago, he had his first failed attempt to cross the CTO, antegradely solely, with Gaia second and Gaia third.
Is it possible we can show them the
About
eyes?
half a year ago, we did
Yeah.
a second attempt to cross, this time from retrograde, via the septal collaterals with different wires, but it was unsuccessfully. We did some diagnostics. He has a mitral regurgitation from his echo. We did a stress test, which shows a large zone of vital myocardium and improvement in the mitral regurgitation. This is the CT scan which we did, which shows the extent of the occlusion and not that big amount of calcium. Okay, so back to the angio room.
So you have...
Okay, so
No, don't go down.
we are here with.
We will wait.
Ivane, can you summarize
Sorry.
the case?
This is the summarize. In summary, this is the patient, our patient, which we tried 2 times, antegradely first, and then one very long but unsuccessful retrograde approach, and now is the 3rd attempt, and you will see the success rate. I will give the stage.
Just,
Shevket.
Yeah.
sorry
Thank
for
you.
interruption. Can I ask Dr. Sianos to comment what he will be doing in this situation?
Yeah, we need to see a little bit more imaging. Do you have any other angulation? Because this cranial projection, I'm not sure whether with the proximal cap, the occlusion, did you make any other views of that? So we can appreciate.
Yes.
Hi guys. So before I further explain the case, I would like to thank Prof. Galev and Prof. Vasilev again for this nice kind invitation. We have a great team here. I am with my friend Stani, and then we have the great team here. And I will show you the thing what we have done so far. George, you are right. You need more views to say something about it. I will give you another view here. This is another view that we have got. This is the right cranial. And you cannot see the osteum. This is going to be a third attempt here. And then here we took in caudal, and in the caudal you can see it's actually tapered. We have a stump there, and it's tapered, but it's very close to the osteum. It's actual an LAD osteal lesion here, and we have good collaterals. And yeah, what would be your approach here? So from here, so I don't want to go further. In order to not to interrupt your discussion, maybe you want to discuss something, and then we can go from there.
Yeah, if I just start the discussion, I would say that there is this cloud of the right injection, but assuming that you have seen it better now, if that is the proximal cup, which is defined, okay, as far as you know where it is, the occlusion is around, it lacks calcification, it's around 20 millimeters long. It looks like that the straight, there is no intralesion tortuosity. On that respect, it's very reasonable to start on the grade and puncture this and see where you can align. That would be the first approach. And the second approach is that they're well-developed CC2 collaterals, but they're a little bit tortuous. So the retrograde should be the secondary option in this. But I feel confident about the great crossing here.
Okay. If you don't have something more to discuss, I can proceed with the case. We have done some work here. And I totally agree with you that we had in mind, so it was 2 times retrograde approach and failed. They were able to cross the septals, but then somehow something come in between and they lost their wires. So I totally agree with you. This is some kind of a little bit, you know, the takeoff is a little bit tricky here. So first what we have done is we tried, what would your choice for wire, in terms of wire, what would you choose here?
You mean
For antegrade?
For antegrade?
For antegrade poking, yeah.
I personally would start with the Gaia next 3, and then just to be sure that I can engage properly the CTO. Or ultimate Bros 3 for navigating through the occlusion for antegrade.
So what about you, George?
It looks like that there is no any big angulation about the takeoff of the LAD. That means that the wire, you don't need a secondary curve, because it's not about what wire you use. You need to have some criteria. I did a Gaia wire, so a wire that it has a curve of 0.5 millimeter at distal edge will reach the entry point. That's one consideration. The second thing is, if that is not the case, then you need to take a kind of an ultimate in order to be able to make a secondary bend and engage. It's also a preference of mine to go directly to Gaia second. I see that you have a wire with a secondary bend, as I'm saying.
This is ultimate.
I don't know what wire is that, but these are the considerations. An ultimate 3 at the beginning to start and engage with the microcatheter, continue with the Gaia if necessary. Gaia second or Gaia third or Gaia first, it doesn't matter. It depends on how the lesion will feel. You can escalate quickly or not. So what wire is that?
So this is the Miracle. This is the Miracle Neo 3.
Yeah, that's also an option in the Miracle family. What essentially you chose a wire that you can secondary bend. That is the key critical point.
So this guy works very well. I like it very much. When I have the opportunity to have my hands on this wire, I definitely begin with this wire here. I didn't want to use a Gaia because, as you know, Gaia is a strong wire and it's not so difficult to go outside the vessel structure and outside the vessel course. And I decided to go with a Miracle Neo 3 here. So, and here you can see what we have done. This is a Corsair Pro XS 135, and we engaged deeply, and then we were able to cross into the diagonal. I didn't change the wire. The secondary band actually didn't give me much trouble. You can see here we are in the diagonal, and then we brought our microcatheter into the diagonal. First straighten the wire and go into the distal vessel. So here, and then we brought our microcatheter deep into the diagonal and then made a tip injection to see whether we are able to fill the LAD or not. So the LAD was not filling, but it could be due to a more deep engagement. We left a run through here, and then what we have done is we engaged the lesion again with the Sasuke. Because we had so much time, I went again with a Miracle Neo 3 here, and I was had not difficult to crossing into the LAD. We could have used the workhorse wire as well, of course. We could have gone into the diagonal, go back, and then go into the LAD, but we had time, so we enjoyed it actually. So what I have done is I have changed to a Corsair again here, and then put a run-through wire over the Corsair here. And now the question was here, whether we can finish with only DCB. I don't want to stand the left main.
What
So,
about imaging?
maybe,
IVUS?
yeah, maybe Dimitar can show you the IVUS. So this looks like from angiographically 2.530 vessel, but it's very different in the, on the IVUS. Dimitar, please, can you show us? Can you see the IVUS, guys?
Yes.
Yeah. Okay.
This is the run after balloon predilatation, yes?
Yeah.
Okay. And you
After 2.5 by 30 millimeter balloon.
okay. So this highly diseased vessel. It is 1, 2, 3. More than 3.5.
They don't hear you,
This is
Dimitar. You don't have
more,
microphone on.
Митко, не те чуваме. Вземи микрофона, ако трябва по-близо до тебе.
Did you dilate the ostium or just the mid part?
Yeah, we did dilate the ostium with 3.0 and with 3.5 NC balloons.
But
And
this is
then,
before this balloon's dilatation. This is after 2.5.
Yeah, before these balloons.
Okay.
So we did also a kissing to the you know, to the bifurcation, distal bifurcation. It was a distal bifurcation. We wanted to finish with the DCB, but I needed a cutting and a scoring balloon. Unfortunately, we don't have that. So I think we will end up with a stent because I have some kind of dissection. I have put a balloon on the main artery for 5 minutes to see whether I can seal the you know, whether I can seal the dissection. But now we are in a stage to decide to put a stent from left main to the LAD, and the question here is,
Can we
Are
see
we
the
going to-
angiographic images that you're
Yeah.
seeing about
Yeah.
after the kissing and this and that? What is your final
Yeah, yeah.
angiographic image?
Shevket,
Yeah, I
moreover,
will show it.
one question, because on the IVUS it was seen that there is a segment with a lot of calcification around 270 degrees, and probably it's around, I don't know, 2-3 millimeters. Maybe on the distal third, it is visible also, this calcium is visible also on angio. This is just around the bifurcation. Do you think that you need a little bit more preparation? You made the kissing.
we have done with 3.5 already.
The ostium
So,
was dilated
if-
with 3.5.
3.5, yes.
Why don't you make the new IVUS?
Because it will not add me something. So if I want to go with DEB, then it will not give me another thing, but I can give you a last shot and show you how it looks after 5-minute ballooning onto the dissection part. So I will do an angio again now, and then we will decide what to do. So can we come to the, yeah, this one is good. We will take one with this one here. And then, okay, so my intention is at least to put a stent till the bifurcation, okay? And then at the bifurcation part, I will do DCB. Or I can we come to the epicaudal? And then I will maybe put a short stent just covering from the left main into the middle LAD, and then treat the rest with DCB. So if I had scoring or cutting balloon, I would have the opportunity to prepare the osteum more, and then it would be a good case for only DEB. But unfortunately, I don't have a cutting balloon. So this is how it looks. So what do you think? So I have already taken a stent. It's 3.5 to 28.
Okay,
So
so as you already took the stent, maybe we will leave you to place the stent and do probably control IVUS, and we will come back just to see in St. Anna at what stage they are, and we will come back in a couple of minutes just to show us.
Okay.
Okay.
That's okay for us. Thank you very much.
Okay, so let's go to St. Anna. Hello, Nikki. Can you turn to the camera and to see?
Hello from St. Anna Hospital. It's our pleasure to have Dr. Ayub with us. We have a patient that probably Dr. Kamburov or Dr. Faranja will show you, because we have a previous attempt of right coronary artery CTO. Can you show the presentation?
From St. Anna. So our second case for today is a CTO case. Let me show you our patient. He's a 63 years old male patient with dyspnea and angina on exertion. He's already on optimal medical therapy because April this year he had an anterior STEMI with PCI of LAD, and later he had in June another intervention of the circumflex artery with a DCB, and in July this year it was attempted to recanalize the RCA CTO, both antegradely and retrogradely, which was unsuccessful. And he's here for his second CTO attempt to recanalize the RCA. These are his lab findings. From the echo, you can see that he has an ejection fraction of 41% with apical akinesis, mild valvular regurgitations, and little enlarged LV volumes. Let me show you the last angio from July this year. So you can see the shots. On the right side, this was Miracle Neo 3, which was unable to cross to the intraplaque space. So that's why we decided to try a retrograde option. Here you can see the septals.
So during the first try, antegrately you stopped with ultimate 3.
Yes, so the integrate.
Some in the middle.
So the integrate attempt was unsuccessful. We tried with Miracle Neo 3, and then we switched to retrograde. Here you can see the retrograde wire going. So our plan was to do reverse card here. We used 2.5 balloon. Here you can see it, but unfortunately the two wires could not meet. Maybe we could have tried with a bigger balloon, but because the procedure was already taking a long time, we decided to stop and to try another time, and here we are.
Okay, so thank you so much for presenting the case. So let me first introduce the team. So thanks to Dr. Mai, who joins me also from Thailand. So Dr. Nikolai from Bulgaria, and to the nurses, Elena is also with us. So we had enough time to talk about the case and to prepare everything. So we have two guides bi-radial, 7 French, and so we can discuss about the approach. We didn't want to do anything, as it's more interesting maybe to show something live. So here you see we just put two guides. We did bilateral injection again, and you see there are some there are collaterals coming from the left, and here there is some taper channel in the mid right. So just to save some time, I will tell you what is our plan. So we put a wire into that RV branch, and we have the channel. So our plan is just to try a couple of minutes integrately, because you never know. Sometimes there are some invisible channels after last attempt, and you just cross. So we are all happy. If not, we would go retrograde and try to make the connection what has been failed last time. So here I show you we have the AL1, and we have our microcatheter in the proximal channel, and again in this case we have also the Miracle Neo 3 on the table, as it is for me a good wire to start to get a feeling for the lesion, and yeah, maybe to cross.
So
Any
now
questions,
you're with the
suggestions?
Corsair. This is
a Caravelle 50.
Caravelle, okay.
So in case we need to go retrograde, I can take it. And this is a Miracle Neo.
No, this is Miracle Neo. This is Scion.
This is
still Scion.
Yeah.
Sorry. This is a Scion, the workhorse wire.
Yes.
Still,
Okay.
give me the Miracle, please.
So the strategy is to cross with Miracle Neo, and
Just to
then
try.
if it's not successful, to go to retrograde.
Yes, exactly.
You don't intend to escalate wires to try some other integrate techniques.
So
just
the question is, we have a bifurcation distally. I don't want to cross with a Gaia third or something like that, because you never know. Maybe I would affect the bifurcation, as you see here. The distal cap, it's somehow close to the bifurcation. You have some channel, but I don't want, if we have this kind of good collaterals, to try aggressively integrately. So this is my approach, but of course, we can also escalate to more higher tip load wires. This is still the Filda XT, the Miracle Neo.
George.
Sorry.
George,
And you see,
how you approach this?
Yeah, I mean, the previous, the strategy has been described. There are many ways to do it. The main thing is that what it comes as a main message is that the previous case, attempt essentially was 99% successful. And it shows that this kind of procedures, they don't have only technical aspects, they have also kind of these strategic aspects. So when you reach this level, it's going to be extremely difficult to fail. And the failure of the previous time shows that still the group has a little bit more to consolidate. I wouldn't say the determination, but the fact that such a procedure at this stage is 100% success. And what happened in the previous that was wrong is that the point of the reverse card was done too early. I mean, if you see the previous balloon dilatation was not done really into the CTO body. Anyway,
exactly
that's the first thing. The second thing is that today I didn't see very much the collateral, but in such a good collateral, the retrograde option taken into account, as Dr. Ayud said, that there is a bifurcation distally, that potentially the retrograde might have some advantages that will respect the bifurcation better. And but
here, George. So
yeah, but
I
think that
I have reached already the bifurcation, but it's sub. So I don't push more because otherwise I would destroy the bifurcation.
Yeah, that's what I see. And if you see the course of this wire is not encouraging. So what Dr. Ayub already said is that I'll try 2 minutes, no more than that. And if this doesn't work based on the fact of such good available collaterals, then the retrograde potentially is the best. I'm pretty sure that with his skills and all the planning, he can take a dual lumen microcatheter, he can do parallel wiring. I'm 100% sure that he can achieve it. You can recanalize this artery antegrade, but it is politically correct to go retrograde in this case. Let's put it this way.
Okay. So
it's very interesting to have a political correct decision during the PCI.
It is. The reason that I'm saying
I first
I will
hear
tell you why.
about
Politically
this.
correct is an extension of my previous talk yesterday. So what I say that the collaterals here are very well developed. The vessel is not calcified. That the expected complications rate of the retrograde are minimal in combination with an exceptional operator. So if you put all of this into perspective, to me, it favors the retrograde. That's why I say it's politically correct to go there. Dr. Ayub, you can give us, because we didn't see any kind of an injection like that from the left.
I will do right now.
To be able to assess the collateral circulation.
I mentioned, bring it close, please, close.
And as we speak, as of now, as Dr. Ayub is working, sorry, Dr. Ayub, what I would say is that the antegrade part of the reverse card has already been achieved. Someone has to say, okay, I didn't cross, but doesn't mean that what he already did is in vain. You understand what I mean? No, his wire antegradely is already in a part to do reverse card. By default, this one is half the job of a successful retrograde procedure. Imagine that he was not able to puncture, or that the cup was ambiguous, or this or that, or whatever. So essentially, he's in a very favorable situation. We see a very good collateral. So I think the pathway should be typical in doing that and not persisting more into the antegrade approach.
I mean, we were also discussing about IVOS control re-entry, but I mean, I don't know if that will work.
I don't believe in that, to be honest with you.
To save some time.
I don't believe.
So here we are already there.
We have seen so many great punctures of a bullseye puncture of the proximal cap that they lead into the subintimal space afterwards. Good puncture with an IVOS guidance in a proximal cap does not guarantee that you're going to go all the way intimal.
This again Caravelle for retrograde?
This is the same microcatheter as antegrade, the Caravelle. We just take it and go with more microcatheter retrogradely. And I took the workhorse wire, which is a Scion, and now changed to the SU03.
I think you're selecting a collateral that was not the same as previous time. Am I correct? The previous time they crossed the collateral that's a little bit more distally.
Yes, this is more proximal.
Yes,
if you see the collateral that
we
is...
tried the second one.
The very continuous collateral is the distal one. That doesn't mean that this cannot be crossed. Simply, I mean, the other one is a continuous, is straightforward, and It might have some advantages on the microcatheter crossing, which has already been achieved, but there is nothing wrong to...
You think we are not in the same, yeah?
You're not in the same collateral, no.
Let me check. Okay, we will do one injection. Aha, we are just proximally, there is a bifurcation.
Exactly.
So what we will do, we will take this as a reference and we will go in with a microcatheter. And here we will go more to the right. Give me Torker, please.
Torker.
This is maybe the one, no?
It is the same.
An additional comment, there is
same,
nothing
yeah,
wrong to
same,
use a
yeah.
sewer wire here, but I don't think that it's also absolutely necessary. What I mean, the collateral is straightforward, and then the sewer is a very soft wire. Now Dr. Ayub is making an effort to redirect to the other branch,
Yes,
but
I
this is not a
understand.
very steerable wire. So potentially maybe kind of a Sion black here might have some advantages. Or of course you enter the collateral first with a normal wire.
But the
and
question
then-
is, do they have the same origin both or two different origins? This is what I don't know. So what we can do also here, to just leave the wire and go with Sasuke. It's also possible. Give me the Sion
Okay,
again, please.
just to go back to National Heart Hospital because they finished, yes, and just to see the final result and
Feel
to
the
come
XTR?
back.
Yes, sure.
Feel the
Can we
XTR.
switch to
Yes.
National Heart?
Feel the XTR.
Sasho? Sasho? We don't hear you. This microphone is not working. Okay, try again. No.
No.
There is no, we don't hear you. Again, we don't hear you. Можете ли да проверите връзката, който от технически екип там на място? Защото има някакъв звук, който чуваме. Очевидно нещо от тия микрофони, някой от тия микрофони работи. Въпросът е
Can
да...
you hear us now?
yes, okay.
Yes. It's always the batteries, you know.
Okay. So,
Just 1 minute to show you the release of the device. It's attached on a cable, and when you're sure that it's stable and when it occludes the PVL, you just rotate the cable and the device is released. Can we have the next, please? The next. And here is the release of the device. If you have any questions, we are here to answer.
just as a comment that at the moment of the release of the device, you should be very careful not to detach part of the system, not to touch any structure into the left atrium. Just sometimes, just as a comment for the audience, not to.
Okay, it's correct, because if you release the device is moved forward and back. Is yes, it's very dangerous. The release of device.
Okay.
You know, you can never predict how it's going to stay after release.
Sure. Can we see the final echo after the release of the device?
That is the final echo.
Can you increase the picture because we don't see? Okay.
We see that there is no persistent paravalvular leak. We see the discs on the anterior aspect. Here you can see part of the disc in the ventricular aspect of the ring. We have gradients that are normal. We don't have any more reversal, diastolic reversal of the, we don't have any more reversal of the pulmonary vein flow. And we checked with 2D for the position of the device. You can see the longitudinal section of the device very, very nicely here, along with the still normal little bit of flow through the device.
Okay, guys, congratulations.
Congratulations, very good job.
Thank you.
Bravo. So, we will see you on the next session, and now we will switch to Pirogov. Hello, Shevket.
Are we?
Hello.
Yeah. Okay.
Again.
Yeah.
Hello.
Can you hear us?
Yeah.
Yes, we
Okay,
left
let
you.
me show you what
we left you with a stand just
Before the stand.
before placing the stand.
So I will show you what we have done. So this is after the stand. So we put a 3.5 by 38 and covered the ostium in a left cranial position, and then we did
What kind of stand was that?
It was Zions 3.5 by 38, and then it was we did a pot at bifurcation, and we have some kind of pinching at the ostium of the CX, and we agreed not to touch it. But what we are doing now is we are here. You can see the distal part of our artery is dissected, and from the stand towards the diagonal and the LAD, we have done Protegi DEB. So this is the diagonal. It's an NC Protegi. It's 2.5 to 20. We put it here for 20 seconds. And then I took another 3.20 Protegi DEB, drug-coated balloon, and then I inflated here for 1 minute, extending inside the stand and extending beyond the bifurcation. And then what we are doing now is we are doing a kissing balloon with low atmosphere here. And now we are waiting at least for 2 minutes or 3 minutes to stick the dissection plane to the vessel wall, and then we will take a final angio, and if we have T3 flow, we will leave it like that. So we are now in that stage.
So you made a kissing for how long? What was
so for now we are about 2.5 minutes, and we will do it for 3.5 maybe, or we can also stop here, but I want to have the drug is already released into the vessel wall, but now this is an NC balloon. What we are trying to do now after the drug release, just to stick the dissections plane into the adventitia.
Okay, while we're waiting, can we switch to Saint Anna just to see?
So we are in a stage now to do the last shot, and then if we have T3 flow, then we definitely leave it like that, even if we have dissection. So we will leave it for healing. But if we have flow limiting problem, then we're going to stent that part as well. But it's going to be only one shot. We don't want to do a lot of shots in order to increase the dissection. So now I'm in the left main now, and you will see the end result. So now we are seeing it together, guys. Let's see what we have done. So for me, this is okay.
Yes.
I will not do
Timothy.
anything else. Do you agree?
Yes. Shortly speaking, yes.
Sure.
What?
Yes, we are agree with you.
We have
Okay, so-
Dimitri fall, so
Yeah.
you can leave it.
So we see a
Yeah,
very
the
good.
dissection is type B dissection, and it's not lumen encroaching, and I leave it for healing, and after 6 months, Stani will make an angio and send it to me, and then we can go further with our registry.
Did you jail?
Thank you very much.
Did you jail the wire into diagonal?
No, it's not jailed. So I took another wire and then go through that stand struts with another
Okay.
new run through. It's not jailed.
Okay.
Okay,
That's good.
nice job.
Congratulations.
Congratulations.
Yeah, thank you very much. Thank you very much.
So let's go to Saint Anna and to be with them till the end of the case. So
Yes, hello. Can you hear us?
hello, Mohammed. How are
Yes.
you?
So
now?
I will show you after you left us. So
Okay.
here we were not able to somehow to get in. So I took the Sasuke. Somehow it helps me for the orientation, but as you see here, I tried to enter to the other branch. But so at what time I pulled? Yeah, here
Yeah.
it was at the end. So I was able with the Sasuke at the end to enter to that other septal collaterals. You can just see at the end, and the Sasuke stabilized my wire. So here, and what we did, we just crossed with a SU03, and so here you see some manipulation
A bit more.
of the wire. So I guess it was the yeah, exactly here. So here we crossed, and then we changed to the caravel back. The crossing with the caravel retrograde here, in this case, it's not that easy, but we managed to cross over that bend because of the bend, I guess. So here it did some work, and we were able finally to cross the bend, and here we are. So we are in front of the bifurcation retrogradely, and the wire were also going to the PL, as you see here. So, and now we will just try to wire retrogradely, and of course to dilate antigradely to make the connection.
What kind of wire is this for retrograde recrossing?
Can you increase the sound?
So we use radius.
It's a Gladius now, retrograde.
Which
So
which
for
Gladius-
crossing,
Gladius
it was the
X?
203.
This is
EX.
Yes.
okay. So Gladius X for retrograde, okay.
And as you see here, my antigrade wire is subintimally, as we have seen from the contralateral injection. I just try to cross a little bit, and what we will do here, we will dilate antigradely and try to make the connection. So give me a guide extension.
Get 7 French.
7 French.
Godzilla 7.
Godzilla 7 French.
So now you use guide extension from antigrade.
Yeah.
Yes, exactly.
Do you have some preferred guide extension? Or you use
I like Godzilla.
whatever you have?
So I mean something which is working. So I don't like to have. But
Yes.
7/7. It has to be 7 French usually. Okay, here you see, because my microcatheter is also not going more proximally. So I will try to dilate also maybe to make the connection or to trap my retrograde wire, which will help me advancing more proximally my microcatheter. If that would not work, maybe we need to change the microcatheter.
Again, this is not the same collateral as across the previous time. And we touched upon a little
Maybe
bit.
not, no.
Yeah, no.
Yeah.
But that shows exactly
Yeah, it's not
the
2.5 by
availability
1.
of the collateral circulation. This collateral has a disadvantage of a big bend that does not allow the microcatheter to be advanced. Because if the microcatheter was now at the tip of the crux, then it would have been a far easier procedure because you cannot control the retrograde wire well. Yesterday we were talking about septal hematomas. If you remember, there was a little bit of a talking, and that's what I was saying.
Okay,
That at this stage, I am uncomfortable personally to push these microcatheters, especially like the Caravel, because these are the microcatheters that then when they find resistance, they tend to deflect laterally.
10, 12.
And this microcatheter, if Dr. Ayub pushes it too hard,
12, 16,
it might cause a laceration of the collateral at this very
16,
distal part.
18.
And as you see, he doesn't do it, and he said that if I need to do that something, I will change to a stronger microcatheter in order to proceed further. Anyway, he will try to do now the retrograde approach by reverse current and guiding catheter extension. But still, to be honest with you, in my view, this of collateral with this microcatheter, even if you're trying to get into the guiding catheter extension and you start pushing this collateral, I consider it as a high-risk collateral. Maybe I would have changed it, but of course, it's very
10,
difficult to give up what you achieve, especially in retrograde
12,
abscess.
16, 18.
16, 18.
And stop.
So, George,
So this is here the crossing.
We have.
It's no problem. It's a guide extension. So now my colleague just mentioning that we have wedge pressure. Maybe you can show the pressure. And this is a guide extension. So usually we don't care if we have wedge pressure. 6, 8.
yes, but this is not something surprising with the guide extension into the
10, 12,
10, 12.
14, 16. Okay,
16.
stop.
into the middle of the closed vessel. And what is the pressure from the left system? As I see, it's normal. The yellow one,
120.
it is 120 to 70. Okay, it's okay.
Yeah.
So
You see here, now it's crossed, maybe stored. So you see there's a good overlapping of both wires.
can you switch back to the fluoro? Okay.
Yeah, can you show that, please?
Yes. Just a second.
Go one back, like this. Okay? Here, okay, this was a dilatation. Unfortunately, it's not safe. But as you see here, both wires are good overlapped over there. So maybe now you can trap.
The
Go.
wire.
10, 12, 14, 16,
16.
and keep it. So now I have trapped my wire and I try to advance my caravel. Oh, okay, it's coming back. Okay, stop.
Are you sure that you trapped the retrograde?
So that means they are
It's
not
interesting.
exactly in the same lumina.
It's interesting when you see the dilatation, you understand that you're in the same space. The dilatation pushed the retrograde wire away. And there was a separation space between the balloon dilatation and the retrograde wire. That's an indication that they're not very close.
Absolutely, yeah. This is what I'm telling when I ask that.
So if you go in a different projection, they might be a little bit apart. Here is a key aspect, is the handling of the retrograde wire, that it's hampered by the fact that the retrograde microcatheter has some difficulties to be advanced. I would have switched microcatheter at this time point. And there are many ways that you can do. You can go to a stiffer microcatheter like the Corsair XS Pro or any of the other thicker microcatheters, or you can go even downsized into a kind of an fine cross.
Probably we need.
And all of these microcatheters might
Do
go
you-
smoother.
Do you think that fine cross will cross this?
Easier, because there is already fine cross.
Yes, but
no,
yeah,
no,
there
no. What
is a
I'm trying
channel.
to say, fine cross is smaller than the
Yes.
than the caravel. On that respect, the collateral is already dotted, and on that respect, I expect that it will go much easier.
I mean, you see it's coming with the diastolic. So maybe just a little bit more patient, it will also help.
Yes, yes, yes. It will go. It's obvious that you have already a sincere crossing there. But as I told you, the major septal complications that I had were, as I said yesterday during the discussion, with these microcatheters, when you push them, by any means they exceed the lateral deflection point and the microcatheter prolapses, it can easily go to the ventricle at the point of the insertion to the PDA.
What do you think about the switching this retrograde wire to another one, just to, because obviously Guadius was stuck there, but
It's not about that. I believe that when he reaches that, as Dr. Ayub is doing now, which is the right thing, when he reaches the crash with the microcatheter, many wires can work. Even this one, he can just redirect it. The vessel is around 3.5 there. There is no doubt it's a vessel, big remodeled vessel, so it allows space. Your undergrade balloon is 2.0?
2.5.
2.5, yeah. So maybe should be enough. Should be enough.
We
I
need a
think
bigger balloon, I guess, maybe.
well, I mean, when your caravel reaches the point of cracks, then you will be able to easily redirect it in the way of the balloon. I believe so.
Yes.
But
No. Provide that.
okay, so now you're moving the caravel slightly in front.
Yes, it's coming with the diastolic, you know, I don't want to push. Okay, stop the balloon, please.
The ejection fraction of the patient was 50%, if I remember right. Nikki?
can we use cranial
41,
projection?
because he had previous STEMI, anterior STEMI, and we
Give
have
the
a
Gladius MG, please.
I'm just
What is
looking
MG?
on the movement of the septum.
we have a primary PCI of LAD.
And 3.5 balloon,
3.5 by
20.
3.520. 3 patent bicycle.
So now you take a 3.5 antegradely to widen the space for re-entry from
Exactly.
the, from
So
the retrograde.
I mean, if you take a look at the last attempt, I guess the main problem was that the balloon it was too small. Okay, 3.5 balloon.
So we are going to 3.5 for widening the subintimal space and then to re-enter from the retrograde back. George, what do you make differently at this point? At this point.
Now that the microcatheter is there, generally speaking, 2.5 for the contemporary reverse cut should be enough. You see that the undergrade wire is
6.8.
buckling a little bit in a strange way. I'm not very happy with the undergrade wire position, but at this time point, Dr. Ayub could have. You see that this is not a good curve that the wire is taking. It's not what you expect. At this time point, is you could get a Miracle Ultimate or a Miracle Neo.
Yeah, but
This is
there's
neo,
overlapping, George, with the retrograde wire.
No, I'm not saying anything. I'm just, you're following. Simply what I'm trying to say now, instead of, let's say, 3.5 undergrade, I might have taken a Miracle Neo or a Miracle Ultimate that shape it well. And
Ultimate, yes.
Yeah, something. Or a Neo.
Okay.
And try to put it in a way of... so there are many ways that it can be done. one of them is what Dr. Ayub does. One is that you insist, it doesn't matter where you insist more, at the bottom line you have to make the connections. And one thing that might be also, Dr. Ayub, why you don't advance your guiding catheter extension more distally? You keep it over there and you do
Because
only
I
the
have-
balloon dilatations.
Yeah.
I would have advanced the guiding catheter extension into the horizontal part of the RCA.
You know, I have problems with controlling the retrograde wire.
I know that, but this might help. There is no need that.
A lot of friction, you know.
What wire do you have now?
It is the Gladius MG now.
Gladius
okay.
MG.
Okay, you can dilate here.
This is Mongo.
We will check in second
Yes.
projection regarding the wire position.
Ники, кой е това водач? Това Gladius MG ли е? Ники,
So this is quite okay for me. Okay. 10, 12.
there is again quite a space, maybe around 2 millimeters distance between the,
60.
at least what we see, you know.
Generally speaking, when I have a guiding catheter extension
18.
inside the coronary, I prefer to advance it personally to the point that I intend to, that it's more likely that the retrograde wire will enter, because that's the point of the guiding catheter extension. Dr. Ayub is now dilating. He might advance it, he might not, I don't know, but he has the procedure and the control. What I'm trying to say is that the wires are done together. It's just a matter of time now.
Salvatore, what do you think
14.
about this
And
stage?
keep it.
I think I would see what, because they are now moving backwards. I think this is not a bad idea. Because you see the wire is more near to the balloon. So, of course, this is a larger balloon. They took a 3.5, if I remember well.
Yeah.
So, Dr. Ayub, this is the 3.5, wasn't it?
Yes. Okay, stop.
3.5 by 20.
And may I ask also, meanwhile,
We have knuckle.
I see you used stress echo for vitality. Do you often rely on it? Because it's very practical in the clinic to shorten the waiting time of the patients.
I think that they are quite
Very
concentrated.
concentrated now.
Yes.
So we have now, they moved a little bit back the extension.
I
and
have
pulled
problems
back
with the microcatheter, so maybe we need to change. What do you think?
To change what? Because there
The
could be
microcatheter?
a lot of things. The microcatheter from retrograde.
I would change the microcatheter from retrograde, yes.
Okay. That was also the suggestion from George
Give me extension wire,
a couple
please.
of minutes
We don't
ago.
have. I think so. Maybe it's the extension.
Corsair Pro or XS? Maybe Pro?
I guess Corsair Pro
The guiding.
should be also okay. Thank you.
And for retrograde wire, you now use Gladius MG, if I understand right.
Yes.
Okay.
Maybe we can.
Give me Corsair.
Maybe you
Corsair
can show
Pro.
the audience the Nanto this time.
Corsair Pro stoji
If the
50.
camera,
Sorry?
if the camera can close up, you can show the Nanto this time while changing.
Yes. Може ли да му покажете малко по-близък от оператора, който е в залата, да се концентрира върху масата?
This case is an excellent example of how much these procedures can be easier or far more complex based on just the selection of the collateral. Because if you take the initial attempt, that a different collateral was crossed, all these issues that
Exactly.
this procedure is
There
failing
were-
were not existing.
Exactly.
Yeah, I totally agree.
So, it's nice to see you struggling, and I'm, te- I'm
I
teasing
know.
you.
Okay, we
In a
finish
way,
it
we
out.
learned a lot by that. But the matter of the point is to.
I mean, we can change to the other one. I don't
No,
know.
no, no, no. I don't say that because you already crossed that. I know that you can do, but I think if you take a stronger
20.
microcatheter, then it will go easier all the way to the crux, and then you will achieve a very nice. But what I'm trying to say also is that it's not about the retrograde access and the complexity of the retrograde procedures and the complication rate of the retrograde procedures and all of that has to do with some details. They might be decisive.
150.
And in this excellent presentation by Dr. Ayub, you see all these kind of concepts that they might be existing. Because many times we put the retrograde under one umbrella, which is not the case, finally, as you can appreciate. So what is that? It's a Corsair XS Pro?
It's a Pro, yes. As far as I
This is a Corsair Pro 150.
So it's not XS, it's a Pro.
Regular Pro.
Sorry?
Yes, regular Pro.
A regular Pro, that's even better. For the audience, the XS means extra small. It's an intermediate microcatheter between Caravel and the classical Corsair. The Corsair is 2.6. The XS is 2.2, 2.1, I don't know, and the Caravel is 1.9. So I believe that the bigger the microcatheter, the safer it is here, in my view. Let's see how can we see the angio now?
Let's see how it does the bending now.
Yeah.
Wow. You have an EBU 3.5 or a 4?
This is EBU 375.
Okay.
I hope that will go. We will see.
Actually, I would have taken a fine cross, to be honest with you, as a second microcatheter. This will reach now, it's moving steadily. But I have seen that the downsizing the microcatheter in these kind of vessels, when they have already been crossed, it goes faster.
But fine cross, George, you speak about regular fine cross or M3?
Any fine cross. The second generation is obviously better.
Yes, exactly.
Obviously better.
Because
but
the
still,
M3 is much better
we
than...
can see if by any means Dr. Ayub has problems to advance that all the way to the point that he wants. We might try it. I don't know if they have fine cross. But it will be kind of an exercise about how the different microcatheters, because I'm always saying the microcatheters are not competitive devices, they're complementary devices. And it doesn't mean that now that Caravel had problems, it's an inferior or superior or whatever, it's a great device. Sometimes you have a fine cross failing and you have another succeeding, so all of these devices are complementary.
But,
So I have the impression it goes much easier now.
Yeah, you reach the point now.
To bifurcation.
Yeah.
So I was not able to reach that point with the Caravel.
Yeah, absolutely.
George, is fine cross your first choice when you have
No,
good
no, no,
collaterals?
no. I'm using the Corsair XS Pro is my first choice as a microcatheter. It's a great microcatheter. It belongs still into the category of the intermediate thickness of microcatheters, and then it's compatible with 6 French guidings, so you can trap it even with regular balloons. For instance, now Dr. Ayub has a 7 French, he can do whatever he wants, but if you take a 6 French and you try to trap a normal Corsair with a balloon, not a dedicated trapping
Give me
device,
new Gladius EX.
You might
or the
might
old
have
one if
problems
it's
to
still
do
working.
So now
In
you
meantime, I'll
switch
take
back
it.
to Gladius X.
4,000.
If
Not
I
so
Yes,
cheap.
because I'm in a very good position now, also with a microcatheter finally, to perform a regular reverse card.
Exactly.
It's not in really good shape, this one.
new Gladius?
New Gladius.
I'm just even wondering that
Yes,
now
you
after
should show
3.5
this.
dilatation, the guide
So this is
extension could
again
be
the
introduced
3.5 balloon.
just to the tip of this retrograde corsair
Okay,
and
12, 14,
to go and to make a re-entry very easier.
16, stop.
But anyway, just
But you see that the undergrade wire is completely offline, eh?
yeah.
And that's why it has this
Okay,
kind of
Gladius?
But this is why I'm
strange
talking
curvature.
exactly to introduce deeper the guide extension to make it as close as possible to the tip. And maybe could be easier. Maybe.
Yeah, but in that way, you miss possibilities to make the connection on other places. Then deeper your guide extension is, then less options you have. You limit your options for connecting.
But always you can.
By
go
which
back.
means you did, so you say that, Dr. Ayub?
Okay, stop. Sorry?
By which means you say that you limit your options?
If I put my guide extension too distally.
No, what I mean, most of the time we put a guide extension in a horizontal part and then within the occlusive segment. So you essentially try to avoid extending proximal or distal.
So here we are already in a very good position. I will pull back my guide extension. We will dilate here one more time. Okay, go.
How much?
12,
12,
14.
14. Oh,
Okay,
sorry.
stop. Stop.
If I make a comment, over there, this dilatation, which is successful, he crossed now.
Okay. Almost.
This dilatation is at the proximal lumen. That's essentially now an extended card. This is what...
It's at the proximal cap.
Maybe not, because you know that your proximal cap is beyond the right ventricular branch. And your balloon is entire now. It's 20 millimeter balloon, which is into the proximal lumen. If you see, there is a long tapering proximal cut beyond the RV branch. What I'm trying to say is
still
that
not in, actually.
this kind of there are many ways that you can just do it, but I insist that the best outcomes and the less complications in the retrograde, as I showed you yesterday, are when you do it really very minimal small balloons within the occlusive segment. And
Yes.
so
Yes,
it's
yes,
crossed
you're
as expected.
Good. Close door.
Okay, give me RG3.
RG3.
But you see also
RG3.
how offline the undergrade wire was.
Ако няма, има в шкафа. Има в шкафа.
6-8.
RG3.
Track,
Едно
please.
розово. Розово.
So now I'm trapping my retrograde wire and I try to go up with the corsair in order to bring our RG3. It's jumped, which is good. I hope we will not show coiling of the collateral today. Okay, stop.
We hope so also.
But we have coils.
Better not to use coils. I mean,
Can you please
to go to
trap
the
again?
point of coils, with coiling.
10.
Okay.
Okay, stop.
So,
Give me the
corsair is
RG3
there.
and 2.5 balloon.
So now you plan to make a tip in, or
Just second.
what next?
Vape ball.
No, we will externalize. RG3?
Just a second, because we have plenty of.
No,
But they
this is
don't
not RG3.
This is 2O balloon that we use.
2.5.
2.5. 2.5.
So, George, what are the options now?
I think that the safest is what Dr. Ayub said. The best is to externalize the wire.
Da, da, da.
I like to work on an externalized wire because it's offer the more support. And there's no way that you can lose. Tip-in is always my second option, unless necessary. in case that the devices are running short or any other reasons too. In this case, it can be done, and he has also a second microcatheter. He can do a lot of different tip-in techniques, but an RG3 wire is the easiest way.
So here we push the wire, it will come from the other
put
side.
the balloon to stop bleeding.
Give me the needle, please.
You can clearly see that all of this process, you see where now the guiding catheter extension is, that there is a lot of tension in the closed system, because now it's a closed system.
Maybe we don't
Antegrade,
need, right?
retrograde, and the system within through the collateral.
Okay, Toka.
You have to be patient, and when you're releasing this tension, the standing will be done. A critical part of this procedure, as it is evolved now, I don't know, maybe it is the projection, maybe we don't know if we see an RAO, maybe it looks better. But the loop in the entry of the collateral is a consideration that the operator has to be very careful. So it is very essential here in this that before he removes the retrograde wire, he controls the collateral integrity.
It stocks, but
This is
it will
RG3,
come.
as I see from here.
This is the RG3. And now I'm removing my microcatheter. You see the left guide is in the aorta. Otherwise, it would go too deep.
In this
Okay,
kind of
here
cases,
we are.
you see Dr. Ayub that he is retrieving the guiding. That's a good technique, but another alternative to that, that adds maybe an extra layer of safety, is that you take a second wire, a workhorse wire, and you put it in the sinus of Valsalva. This wire will not allow the guiding catheter to dive under any circumstances.
And you also avoid this back and forth movement.
Yes, because whenever you have a lot of resistance in retrieving the
Prepare the
microcatheter,
Sasuke,
you might
please.
not be able to completely control the
And
guiding.
Scion wire.
If you put a wire into the... But you have to make sure, one of the things that people are sometimes putting this wire, the body wire, only the radio pack so they can see it, and because it's a soft part, it might protrude in the left main under push. It has to be pushed quite
But then
deeply.
it doesn't stop the catheter from
Yeah,
moving.
so you have to push it quite well to be on the stiff part of the body of the wire.
12, 14, 16, 18. Stop. Prepare 3-0 long stent, 48.
Sometimes I
Okay.
have an
18.
internal sensation that
20,
CTO operators follow the old principles of bodybuilders. If you can make something simple, make it as complex as possible.
No, it's a very good case about, as we discussed before, that the selection of the collateral might sometimes affect the procedural complexity. Because in this case, there was never a concern about
3-0,
success. It was going to make the connection anyhow.
So here I will try to wire the PL and dilate just for safety reason. Okay, Scion. Give me the Scion. Here we are.
So this is a dual lumen microcatheter they use for the selection.
Where is the LAO? Where is the...
When you are having more than one wire and an externalized wire, you have to be very careful. That is a very big thing.
17,
Because sometimes you do the stenting,
12. Okay.
and if you forget your stealth,
Fresh one.
you might stent over the wire into the PLA and not over the RG3. And with the stent, you can trap the externalized wire. That might be a problem. So whenever you have this kind, when you're achieving or when you're putting a second undergrade wire like this way, I prefer to exchange the retrograde wire personally. I don't leave it as a wire of stenting just to minimize the risk of
Okay,
By
stop.
mistake, he dropped the
Refresh it
retrograde wire.
Store. So here, this is the provement for me that I am true at the level of the bifurcation. Okay, 20, because the cyan just went very
20,
easily.
20, 20, 20, 20, 20, 20.
Okay, give me 2.5 balloon.
The worst one?
Yeah.
Yeah. Permission.
We will dilate towards the PL and then just put stents from the PDA to the proximal RCA. I hope you agree.
So will you leave your retrograde wire meanwhile?
It's the new one.
New one,
New one,
2520.
25 by
If
20.
his strategy is
Sorry,
to,
again?
if the strategy is to, the question was that you're going to leave your externalized wire. We had a little bit of a discussion as you were working about when you have more than one wire and one is externalized, to be cautious enough not to trap the retrograde wire.
Exactly, this is...
No,
but as
we
the
will
strategy of Dr. Ayub is now is to stand over the PDA, then this risk is not existing because the retrograde wire is in the PDA.
So we will stand towards the PDA. What do you think, George?
Yeah, I think it's a good strategy from any point of view.
Okay.
But as you said, the easy access of the wire to the PLA, it's an indication that the distal bifurcation has been respected.
4. Only 4.
I'm just wondering why not
This
to
is a 2.5.
take a microcatheter over the externalized wire to replace the retrograde wire, and to work antegradely on the regular wire.
It can be. It can be.
Just because then you can and leave the microcatheter into
Yeah,
the channel
absolutely.
just for safety.
Simply, it's an extra work. That's the only concern. That, in order to now to change the undergrade wire, the externalized wire, you have to take your caravel. You have to put it there. You have to retrieve the retrograde. And in this case, I wouldn't do it just because I have a concern about the collateral.
3548 and
So I prefer to finalize the procedure and the stenting over this RG3. Finish whatever you have to do with the right and then check the collateral integrity, because if there is a problem with the collateral, which it seems not, then you better have an externalized wire to do whatever you do.
So, guys, you dilate it to the posterolateral branch with 2.5 balloon?
Yes, just to be able to re-enter once. So for me, this is a provement that I am in the true lumen at the level of the bifurcation, because only cyan crossed. So, and here I just dilated to make some space to keep it open for later on. Okay, go.
And this is a balloon or stent?
It's a stent.
This is
It's a
already
3/0
stent.
stent.
Stand.
Okay.
3 by 48. 6.
8.
This is Xion Synergy. What type of stent is that?
Science.
You see by the dilatation, this dilatation explains a little bit the problem. The balloon is not expanding easily.
Yes, there was
And that's an
some-
indication that the vessel calcified. And quite a lot of the issues that there have been with the wiring, that's what I was telling you yesterday, that you learn and you understand the problems that you have during the procedure when you finalize it. So a balloon at 8 atmosphere didn't fully expand, and that shows that over there, this horizontal part of the right coronary, you have
Give
some
me the 3.5.
calcifications.
3.5 stent.
Okay.
So the mid right with 3.5 to 48 or something different?
Yes.
Yes.
And the lesion that was not dilating, this was exactly the point where it wasn't
We
able to do
dilated.
the reverse
We
cut.
made
Exactly. So
reverse
the
cut.
undergrade wire was redirected because it faced a kind of calcification undergradely, and then created this kind of...
Clear stent, please.
You can activate it with the upper right pedal.
Clear stent. Is it on?
Yeah, upper right pedal.
Upper right, okay. Here.
Probably.
So I will go up to the ostial, and then if needed, we will put one in between. This is contrast, yes?
Yes, it is.
It's also important because we didn't inject since we have begun with a procedure antegrade. So for that, I always flush.
Did you check the CT?
Yes, we checked. It's already okay. We gave also 4,000 20 minutes ago. And now, but I just flush additionally because you never know.
Because we're more than 1 hour away from the beginning.
Yes, also, yeah.
Just
So here we will check the pressure first before we inject. Pressure is again okay because the guide extension is pulled back. And here we will check the osteum. We need to come a little bit more back. So like here maybe. Okay, that's fine, go.
But probably we'll miss the junction.
No, go.
But we are not connected. Just a second.
he intend to
Go.
place
I like
a third stent
Now?
between the distal and
Yes,
proximal.
exactly. Exactly.
Just
Because the
cover
osteum
to
was
secure the
also
osteum
diseased.
and then to
Exactly.
to fix
Exactly.
the mid portion.
If needed,
Okay.
we will put one more stent.
Yes, there was some. What is the pressure of the balloon at the moment?
18,
20.
20.
Okay.
There was a bit of resistance to dilation at the proximal cap.
Yeah.
Yeah, this is the point of re-enter.
The good point is that they have
So-
a good pressure.
Here we will advance the guide extension over the balloon. And then we will go more distally with the balloon. And wait a little bit. Okay, go one more time here. 10.
Here, 10,
Uh-huh.
10. We're up to 10,
12,
12.
14.
Do you
14.
plan to do some IVUS for
Six.
stent optimization?
Yes.
Okay.
Okay, stop. We will do.
Just at the end to be sure that there are no
Do we have any
some
gap?
hidden
Let's see if we
surprises
took a
for stent expansion or.
Just a second. You can use.
We have a gap, yeah?
Yeah, we have a gap. Probably 3-4
Our
millimeters.
position is barely probable, but
358 stent? Or, yeah, 358. 12. Give me 12.
3-5, 12 by 12.
Yes.
Stent.
so okay, they're dilating to 3.5, and the initial stent was 3.0 because I saw that there is
20 and, see?
some quite a large discrepancy between the distal tip of the balloon and the size of the initial stent. Maybe there is
Can you
some
increase
under
the sound,
expansion
please?
at the distal
Here,
part.
very bad.
Yeah, looks
Don't
like
you
an under
know,
expansion at the PDA bifurcation.
Exactly.
The sound is outside. That's why probably.
But it's
This is why I was talking about the IVUS, because at least for educational purpose, George. Okay.
No, I mean, it's, I would say something in these two kind of cases that they performed, it shows also the completely different, let's say, thinking and attitude of the operators from the very extending stenting up to the minimal stenting. And this is an evolving issue into the CTO PCI. For instance, in this case, you could have finished the case with one stent, do an DCB in the proximal RCA, avoid the overlappings, avoid
Okay,
you understand what I mean? Personally, I also don't like the small gaps because, especially in the mid RCA, because the overlapping
14,
segments are
16,
working as
18,
fulcrums and they're predisposing the long standing into fracturing. So you have a very short stent in the middle, as here, and you have two overlapping segments, and in these segments in the mid right, that it is the most mobile But part of the,
it
the
was
heart.
all diseased,
These are the
George,
places that we
up to
see
the
stent
proximal
fractures.
part.
Let's see.
So I don't like that. Yes, to optimize a little bit because from the, how do you call it? You see here what we were talking about, that the distal cap essentially is after the RV branch. So you saw the initial procedure of Dr. Shefket that he said, okay, I will try to go just with the DCB. Of course, Dr. Ayub is also the leader of the DCB trial. This is the classical, of course, stenting
Yes, but
procedure.
this is a good demonstration how the stenting should be done.
Yeah, if you do that, then you better do it right.
Exactly.
You understand what I mean? This is the time that you do this.
Maybe now it's time for
Give me
IVUS.
IVUS?
Okay.
Yeah,
Yes, now we will do IVUS and kissing for the PL branch.
Yes, to optimize
Do you want to flash it a bit?
the stand to
Yes.
achieve better
5
long-term
minutes.
outcomes.
Да-да. Yes, you have 5 more minutes for the live transmission.
Yes, it's good. I guess we deserve that.
Sure.
Thank you. Okay.
Do you want to switch to Andrew there?
No, it's okay.
It's fine. Flash, just a second. Oh.
Come.
Maybe it would be good at the beginning of the next session to show us the last pictures for checking after checking the collateral.
So
Nikki,
working, but why?
just because
Da.
we certainly would not have enough time to see that. Probably after IVUS we have to switch off the transmission. We have 4 more minutes.
Okay. Good.
But it would be
Yeah,
good
but you
at the
see
beginning
here-
of the next session just to show us the
it's
state
okay.
of
It's okay.
collateral. So can you show
Yeah.
the IVUS now, the operator from the room? Can you go
Yeah,
switch
I'm
from
trying, but you see the picture, it's too dark. I don't know why. You see here, I'm flashing. You see the stent, but
this
it's too dark. Why?
No idea.
This is assist
It's too
system
dark.
or this is Boston?
No,
So
it's
it is
Boston
okay.
IVUS.
So you have to remove the catheter and to flush it again. Probably there is a lot of
We flashed
air.
already. So here is a pullback. Yeah, it's dark. It's not
No.
air.
You have to flush the catheter, otherwise it would not work.
You see, here are the stents. But now you will not see anything. Okay, sorry for that. We need to manage. We flush it again.
Yeah, I'm trying.
Just flush the system 3 times
Just a second.
with the full syringes.
So here we are flushing
Good without the air
very
there.
well.
Let's check the
Check now.
image.
Go for live.
Yeah,
Go for live, please.
live. No, it's not working. I don't know why. Do you think it's connected?
Okay. So Dr. Mai will fix it. I hope he will be successful.
Okay. But anyway, George, can I ask you for some summary of the case
No, it's still, you see,
from our
it's
side?
too dark.
Yes. I think it was a very well done case. It was a case that, again,
and
on a
4-5
second
Sivalon.
attempt, short integrate attempt, then shifting to parallel wiring, and
4-0.
nicely
4-5,
done
20.
reverse cart.
4-5.
So a classical retrograde procedure that addressed all the issues about the balloon size, about the extent of
It's
the
okay.
stenting,
For all.
about how you make the connections, where you make the connections, and
I mean, if you see George regarding putting stent in the proximal, it's all deceased. I don't know.
no, I cannot argue with
You know,
that because
I mean,
nobody
I'm
can
doing a lot
argue with
of
success.
TCB.
Yeah.
No, I'm doing a lot of TCB, but
I know,
not at any price. And we still don't have data, so I don't like so to say, okay, will be better. We don't know. I'm
No,
doing
no,
a
no, no.
randomized trial, you know that.
I know
But
that I mentioned that you were leading the DCB trial. Simply all of that's a discussion for the audience. It's not about, there is nothing wrong and nothing right.
No, it's not working.
But I believe that if we minimize stenting into the CTOs effectively, the outcomes would be better, in my view. So on that respect, it's a very good result. The PLA has to be worked out a little bit. So that was it, a nicely done retrograde. This is a typical reverse card procedure, guiding catheter extension reverse card.
Some final comments from
So-
the rest of the panel? Dr. De Rosa?
No, congratulations, excellent result. Of course, they will now go for and check the collaterals. I think we will not be able to see it. But,
We will see it
later.
maybe in the
We can
next,
do it
next
together if
session,
you give me
at
2
the beginning
minutes.
of next
Okay,
session.
10, 12.
But actually, at the end of the day, the Proxima stent was a good choice because we see now a wonderful lumen.
14.
Okay.
So now next question to Nikolai and Mohammed is what the antiplatelet treatment downwards would be for you.
Yeah. But maybe that will be commented
this is a
just
question for you.
on the next session because we have 20
missed the
seconds.
question.
So let's congratulate the operators.
Thank you.